So just to go over again what an uncomplicated UTI is, well, it's pretty much those young female patients that aren't pregnant, that don't have any abnormalities or any other risk factors, and basically everything else is complicated. And that is important because it makes a difference to how long you're going to treat them. They're going to need at least 7 to 14 days if they are complicated. So just a short word on asymptomatic bacteriuria, just to remind you that this is growth of bugs in an asymptomatic individual. It is actually quite common. There's, usually I think it's about 2 to 3% of the population in normal healthy population will grow bugs and be asymptomatic, and they're equivalent to commensal colonization. But one shouldn't forget that these commensal bugs, or at least these asymptomatic bugs that one cultures, can be protective, and that you shouldn't really be treating them unless there is proven benefit for the patient, because by treating them, you can eradicate a population of bugs that's not causing disease, and you may then select out more resistant bugs, change that commensal population, and put the patient in a situation where they then get recurrent infections with resistant organisms. Just following on from that group of patients in asymptomatic bacteriuria, you shouldn't really be looking for it or treating it in patients who don't have risk factors, in patients who are well-controlled diabetics, in postmenopausal women, in elder institutionalized patients, in patients with abnormal lower urinary tract, even patients that are catheterized, in renal transplant patients, in patients prior to arthroplasties, and specifically in patients with recurrent urinary tract infections. There's, in fact, evidence that by treating patients who have got asymptomatic bacteriuria, if they're known with recurrent urinary tract infections, that this could in fact put the patients at a disadvantage and actually increase their risk of recurrent UTIs. So then just looking at patients who are presenting, complaining of recurrent UTIs, I think it's important to try and weed out those that are in fact recurrent UTIs from those who need a little bit more attention and perhaps on referral and investigation. And I think a lot of those things you find in the history. So those are the patients who might have a bladder cancer, and the most important risk factor there is smoking, and that's obviously dose dependent. The more you smoke, the longer you smoke, the greater your risk for bladder cancer. Also patients that have had high exposure to occupational pathogens. Those are patients that work with dyes, or basically any chemical industry. I think even nursing staff working in scope theatres where they're sterilizing instruments have an increased risk, and colorists who are dyeing hair all day. So it is important to ask about occupation and smoking history. And obviously also radiation to the bladder. Patients who might have genitourinary TB, and I think the most important thing there is that you can have very young, healthy, well-fed looking patients that have genitourinary TB. So it's not just contact, it's looking for other things. It's looking for symptoms that don't resolve, patients that have recurrent negative cultures with white cells persistently in their urine, maybe a little bit of blood, and patients that might have had GUTB before. Also, bilharzia, ask about contact, but you should pick that up if you're doing a after T urine MCNS. You should pick up those patients with eggs in the urine, and obviously the RT painful bladder syndrome patients. It is also important to make sure that they're emptying. That's as part of the workup later on. Also ask about recent hospitalizations, because we do often see patients who've recently been hospitalized and become colonized with quite a resistant host of commensals, and then get one UTI after the next. It's also useful to ask about previous UTI issues, especially those who have had issues in the pediatric age group or earlier in their lives. Very important to ask about surgery. We, in fact, had a very interesting case who presented with recurrent UTIs, and we didn't ask her about previous trauma, and we eventually found a bullet with a stone on in her bladder. Now, that's quite rare, but it's quite important to ask about previous surgery, especially the older type surgeries where they were doing suture suspensions, because we've seen a few of those land up in the bladder as well. And then also ask about pneumaturia in the older population group, because they can be a little bit tricky. They don't always tell you that they're passing air in the urine, but they obviously, if they've got a connection between the bowel and the bladder, are going to have recurrent UTIs and come back again and again until somebody figures out that connection. Okay, so patients always want to know, why me? I hate having these UTIs. My life is terrible. And obviously the package of risk factors is different in the young premenopausal patient versus the postmenopausal. So in the young group of patients, it's related to picking your parents well, so related to family history and blood group antigen secretory status, but also largely related to the sexual history. So important to ask about that. In the postmenopausal group, it's more related to estrogen status and to incontinence and catheterization and being frail and elderly or being in a care facility. Okay, so moving on to diagnosis. So I think this is one thing we see quite often. Patients will tell you they've got recurrent UTIs, but they've only got one positive culture. It is really difficult to get this history sometimes. So I think once a patient is going into that range of being is this a recurrent UTI patient, I think the times of treating on symptoms and dipsticks are done. One needs to culture these patients when they're in that group. I currently have a patient that's got a carbapenemase producing Klebsiella. And this is a community-acquired bug. So unfortunately, once you're in this group, you need to culture them every time they present with a UTI. And then just to remember, in those patients that don't have recurrent UTIs, if you think they've got pyelonephritis, if the symptoms aren't resolving, if they've got strange symptoms or if they're pregnant, then you should be doing a culture. Okay, so in terms of investigation, just to be honest with the patient and to all of you, we investigate these patients all the time, and we most of the time find absolutely nothing correctable. Most of them don't have a high post-mic or anything else. Every now and again, in an older patient, you'll find a small kidney stone or something like that. But in most of those patients, even if you fix those, they tend to just carry on with their UTIs. The ones with a big residual volume, if you fix that, that often does make a bit of a difference. So if a patient is young and they don't have other risk factors, you probably don't have to do an extensive workup beyond just making sure that they're emptying their bladder. So in the funny ones where you think they're not presenting typically, those are the ones where you should be looking further. The rest, if they're young, you're not going to find anything. So we always
Lisa, sorry, can I just ask you on this?
Yes.
So, I mean, obviously, you'll probably get onto this maybe later, but, I mean, this whole issue of the painful bladder syndrome or interstitial cystitis or whatever else you want to call it, I'm finding the overlap to be quite significant in some patients, and a cystoscopy is often helpful to see if there is kind of underlying patients. What is your thought on that? Before you actually embark on a treatment, especially in patients who've got a large component of pain or pain between.
No, I think definitely that's in the group. So if they've got large amount of pain, especially pain that doesn't resolve in between episodes, then I think that's important because TB of the bladder can present like that too. So I think in the patients that are not resolving in between and that have a very large pain component. And I think a lot of that you can get from history. They'll tell you in between, when their bladder's full, it's painful, they empty a bit, gets a bit better, it stays painful. And you might also find other things when you examine them in between, that they've got tenderness in the pelvic floor, they have a bladder that feels tender, they've got all kinds of other things that go with that group of symptomatology as well. So I think in that group of patients, yes, definitely, I think having doing a scope is very helpful.
Okay.
So just going on to the behavioral modifications, we always talk to patients about it, but most of them have figured this out. They've spoken to their mom or their auntie or their granny, and somebody's told them. So they all figure this business out. I think one of the things that they do sometimes not do is this falling asleep after having intercourse. So that's one thing you have to remind them about, especially the ones that have the recurrent UTIs related to coitus. But strangely, there's not much evidence for this. I suppose it'd be very difficult to do a proper study looking at this, but there is limited evidence. We do tell patients to do all these things nevertheless. I'm not sure whether it helps or not, but definitely gives them something to do, I suppose. This is quite an interesting study looking at water intake, and unfortunately, it's only really been shown in premenopausal women that drink small volumes of fluid to actually make a difference. But in premenopausal women who drink less than 1.5 liters of water a day and who have recurrent UTIs, if they can increase their water intake, this can definitely decrease their cystitis episodes and their antibiotic usage. And there's reasonable evidence to support this. So it's always something to ask about, especially those that are running around and not drinking enough during the day. I think they don't realize how little they're drinking. And so this is something that you can try. vaginal estrogens. So I think almost all my patients that are postmenopausal, I'll give them vaginal estrogens to try and decrease their UTIs. So definitely does have evidence that it reduces UTIs. It's superior to placebo, not as good as antibiotics. But just to note that oral estrogens don't have the same effect. So if they are on oral estrogens, it might be something that you can consider if they're not already using the vaginal estrogens. Then moving on
Lisa,
to
sorry,
vaccines.
Lisa, sorry, I'm to bother again. Are
No
you
problem.
using Vagifem, or do you normally give them Premarin, or which one do you prefer? Do you feel the cream-based
I don't think
replacement?
I don't think there's evidence that the one is
No, I
better
don't
than
think so
the
either.
other, as far as I
No,
know. So I think
no.
it's pretty much a patient comfort thing, I suppose. I find a lot of the older ladies, they don't want to shove things up there, you know. So they feel happier literally manually putting this cream on the finger and putting it in there, because they don't want to kind of have anything in their vagina or stick anything in there, because they're afraid to cause injury. And in those patients, I think the cream is definitely better. So I think most of the older patients tend to like that, and I think the kind of the younger patient, they tend to like the idea of the Vagifem more. So I don't think it matters which one, just as long as you're giving them something.
I think on first principles, though, to be honest, I think using something that is more cream-based, you might get a little bit more of an effect on the external genitalia, which in principle might work better because of the impact on the pH. So I do tend to maybe prefer giving my patients Premarin, but you're right, there's absolutely no evidence or any of that.
Yeah, I've actually, for the ones, the patients that are very hesitant to use, applicators and things like that, I actually don't care much for the rest of the vagina. I just want it around the urethra. So I basically, even if they can literally get it onto the hole where the pee comes out, I'm happy. That's what we need. And they seem to get that. Okay, so the next thing is vaccines. So yeah, this paper's conclusion has a systematic review has concluded that there definitely is evidence for efficacy, but unfortunately there's quite a lot of heterogeneity, and I'll go through some of the things that are available internationally and some locally, and you'll see why they say that there's an issue with heterogeneity. So these are looking at some of those that are internationally available and not locally. You'll see that there's quite a difference as to the delivery mechanism. Some are oral, some are vaginal pessaries, some are intramuscular injections, some only cover E. coli, and some cover a broader range of organisms. And I think that's probably why the evidence is a little bit all over the place. But despite that, they do seem to work. They have a good safety profile. And there is quite, if you look at this, these recommendations are from the European Association of Urology Guidelines. They have quite the evidence, as you see, it's 1A. It's not bad, it's I think, and it's got a strong recommendation. We don't use it a lot locally, and I think that's probably because before we haven't had anything available. But we do in fact have something locally available. It's actually, strangely, I ran into the rep in the passages at Christian Barnard today. That's your email at the bottom. It's not too expensive. I think it's about 3,000 Rand. They need to use it for 3 months. Some of the funders will pay for it. And it has good evidence. It does seem to make a difference. And it covers E. coli, and I think Proteus. I think there's 2 other organisms, I think. It covers. So it's got a broader cover, and I think it is something that one should be trying. I think 3,000 Rand is not breaking the bank. And considering what these patients pay in terms of in pain and suffering and recurrent antibiotics, I think it really is worthwhile. So it is something that you can consider. Write down this lady's email. She will help you. Unfortunately, it's not registered in the country, so you have to do a Section 21 application, but it's a consent form you need to do with the patient, and the suppliers do the application for you. I think it's an extra $300 or something for that separate application for that Section 21 application. Okay, the next thing is probiotics. So people always talk about yogurt, but this is actually orally taking antibiotics, and these are the ones that apparently have the highest efficacy, but there's not really much data on how much you need to give, how long you need to give it, and what particular strains you need to give. So it is the data is all over the place, but it does seem to make a little bit of a difference. Unfortunately, we don't have combinations that locally that I know of that have exactly this mix. So whether or not this is useful, I'm not really sure, considering that the evidence is all over the place, and many of the kind of the locally available probiotics don't really have all of these ingredients. So use it, don't use it. I think there's other options which have better evidence and that are locally available. So I haven't used them. I'm not sure, Steve, if you have any experience with these.
I have been through a phase of using Ritalina. I've used the Multiflora Woman, but about a year ago, I spoke to one of the microbiologists, and they suggested you use Probiflora 9, which become my go-to one. But I'm a very firm believer in the microbiome forming an important part of our resistance against recurrent UTIs. And so in anyone with recurrent UTIs, I do insist that they do take some probiotics. And then I also just encourage them to look at their diet, what they're taking in terms of their fruit and veg and their general exposure to microbiome and improving that. So I actually say to patients they need to take 20 types of fruit and veg every week to try and focus on that. And even including a bit of wine, I think it does have some micro effect. So, but anyway, that's just my take on the whole. But I think it's recurrent UTIs as well. But I don't know if you're going to be touching on that later, Lisa. But it is a very
No,
important
not really. I think when
Yeah.
it comes to the microbiome and all of the urological conditions, there's a lot more work being done and a lot more metabolomic work being done. They're even now in the recurrent UTI sphere doing these extended cultures where they are trying to culture the poorly culturable, the unculturable organisms. And there's this belief that in many patients, we're actually not culturing the bugs that are causing the recurrent UTI. So patients may present with the symptoms of a UTI, but when you culture, you don't find a bug. So there are the other bugs like mycoplasma, and there's a whole host of them that we don't catch them in a normal culture. And I think that's where a lot of the thought is in this kind of giving longer term antibiotics and broader antibiotics and prophylactic antibiotics, that one's actually targeting those bugs that you actually aren't treating or identifying and can't target well, because you can't culture them very well in a standard culture. So I think there's a lot of work being done. It's quite interesting. I don't know when it's going to be prime time, but I think that's beyond just the microbiome. That's actually looking at infective organisms. I think when it comes to the microbiome, I think the metabolomic type studies do give you a reflection of that. But the problem with that microbiome is, for instance, in stone disease, they have done work trying to repopulate the gut with oxalate degrading bacteria, and they've been quite unsuccessful at trying to populate the gut with better bugs. There also seems to be quite a broad variation when it comes to the gut microbiome across diets and across population groups in South Africa. But you are correct, the diet plays a big role, because I think at Tigerberg, they're doing a big study looking at the microbiome in colon cancer patients. And it's quite interesting that patients that move from a rural to an urban setting, they do have a shift in their microbiome. And so you are right. If you eat rubbish, it does mess with your microbiome. And you're right. It's vegetable fiber as well, because obviously a lot of these organisms, they live on cellulose and on oxalate, which is very high in green vegetables. So yeah, I suppose you are what you eat.
On that point, Lisa, I had a patient who was really at the end of a tether with the recurrent UTIs and being managed by a physician. They actually end up going for one of these fecal transplants locally with one of the doctors in Cape Town. But she actually had a remarkable improvement. And by saying bad UTIs, I mean she was in hospital for 2 weeks on an IV. So but I don't say we should be giving everyone a fecal transplant for that, but there is something in it, and I think we'll see a lot more press on this in the future.
Yep. Okay, so the next is cranberry. So yeah, so I think the problem with cranberry is we struggle to get proper cranberry juice here. I think Steve has actually told me that he's spoken about this Allura this week, which it actually gives you, I kind of went to read up, and it actually gives you proper doses. I think that's the issue. People think that they can just drink the cranberry juice off the shelf, the liquid fruit one that's basically 99% declarified apple juice with a little bit of cranberry extract in. And I think that's where the problem with the evidence comes in, that there's been quite a lot of different concentrations and bioavailability. So I think if there is, it's not going to harm you. It's fruit. Can only help. So I think if you can get your hands on it, I think it's not a bad thing to recommend, to be honest. And really it does enrich a healthy diet. The evidence, as I said, is all over the place. So that's why it only has a weak recommendation. The next thing is D-mannose. So that's one of the other health shop alternatives, and there is limited evidence that it works, but there is some evidence that it works, and that's probably why it has a weak recommendation. The problem is, though, that we're not sure about the dose, 1 to 2 grams divided into divided doses. And how does it work? It's an inert sugar, and it actually, for those of you that's forgotten how what these type 1 pili are, there. There's these little Velcros on the outside. I call them Velcros because that's what the D-mannose does. It actually goes and coats the E. coli. It does work on some other bacteria, so there are some others that have got type 1 pili as well. And by doing so, prevents the organism from attaching and invading the mucosa. So this is something, it seems to be quite well tolerated. It's widely available at health shops. I do recommend it. I've had kind of mixed results of it. Some patients, they love it and said it's made a massive difference, and others said, no, it hasn't helped a dot. And I think that's the issue, that it does seem to have variable efficacy. And I'm not sure if that's probably because if they don't have type 1 pili, it's not going to work, and they're mostly found on E. coli. So if it's a non-E. coli kind of UTI or colonization, it's probably not going to help the patient at all. The next drug is methenamine hippurate. It actually gets broken down into formaldehyde and hippuric acid. So it acidifies the urine, but the formaldehyde is also bacteriostatic. But according to this health assessment report, it doesn't have any teratogenicity or carcinogenic effect. There is good evidence that it works. I have not got any experience with it, so I really can't advise you. Steve, have you got any experience with this? I don't even know if it's available locally.
Yeah, that's the problem. It has actually, the people who use it overseas find that it does work, and it is actually one of the first lines in the guys who use it, but it's not available in South Africa, unfortunately. One of my patients' husband is a pharmacist. He really tried to get it. He tried to import it into South Africa, because he also looked at some of the evidence into this. So it's not available up until a few months ago when I last looked. It sounds like it is actually quite a useful option. But
it's quite sad, because it's actually got a lot more robust evidence than many of the other alternatives.
No, I wish it was available. I was trying to get maybe one of these compounding pharmacists to make it for us, but I don't think we got very far with that either. So yeah, it's not an option, unfortunately.
Okay, so the next group is the gag layer targeted therapies. So these are installations that I can never say this, chondroitin sulfate or hyaluronic acid, and they really are supposed to replenish the gag layer. I think the original evidence for this was in the radiation radiation cystitis, interstitial cystitis patient group, but there is now good quality evidence that with the combination, it does decrease your UTI rates and your time to recurrence. So unfortunately, as I said, the combo does seem to work better than single agent. And unfortunately, the only product we have is locally is a single agent product. As I said, it replaces the mucus layer, and that product is Cystastat. It is available. The problem is that you have to catheterize the patient weekly, and that can be a problem in patients who have recurrent UTIs. So unfortunately, if you are going to use it, you need to make sure they don't have an active UTI. you probably should be giving them a prophylactic antibiotic dose. And I found that the hydrophilic catheters, the single-use hydrophilic catheters, the pre-lubricated ones, they seem to work the best in this patient group. I have had some success with it, but it is quite a pain, because you have to go and put it in every week, and every week you have to make sure they don't have an infection. When they have an infection, then they have to retreat, interrupt, and restart. And it does seem to have a prolonged effect after you've stopped it. So this is an option. It is locally available. Steve, have you had some experience with this stat?
Yeah, I have used it in some of the patients with recurrent UTIs. It's kind of a little bit far down my list of options, simply because it's really expensive. It's about at least
Yeah.
2,000 to 2,500 rand per treatment, and then
Yeah.
the patients have to pay to have it inserted. So after 4 treatments, you're about 10,000 rand down the line, and if
Yeah.
it hasn't, then the patients are even more upset with you. So, but again, it's not a bad option, especially if you've done a cystoscopy and you've seen some possible inflammation or something that might suggest that it's interstitial cystitis. And I don't think the evidence is bad for it. But it's a pity that they haven't really been able to get this paid for by the medical aids, because I think that would be a great option for a lot of these patients. But again, I spoke to one of my patients, a GP, who asked me for another course because it did actually work in her. So I actually literally just spoken to someone a few minutes ago about this. So yeah, not a bad option, but again, I mean, all your points about the catheters, etc.
Okay, and then we move on to the antibiotics. So there's a few different strategies. There's the continuous low dose, which I think we use very often in the patients where we've exhausted all our other options. The next is the post-coital administration, and the last is the self-administered, self-started antibiotic. So obviously the continuous, we give low dose for longer periods. It seems to be equivalent in the patients that get post-coital recurrent UTIs to just giving a single dose. So whether in that patient group giving them continuous low dose versus only giving them a dose around coitus, the efficacy seems similar. I'm not quite sure how long you need to give it. Is it 3 months, 6 months, 12 months? I usually give a minimum of 3 months. And the problem is, if it works well, you really struggle to get the patients to stop taking it if it's worked well. In terms of drugs, the recommended drugs are macrodantin, fosfomycin, Bactrim. In pregnancy, these ones, Kefalex and the Kefaclor. They actually don't recommend Augmentin because of the environmental pollution. Apparently, we're peeing it into the water, and it's bad for the environment. And the quinolones tend to just breed resistance, and there's been quite a lot of issues, or a lot of extra concerns highlighted related to quinolones because of not only the tendinitis, but also some of the neuropsychiatric side effects that it may cause. So it has really fallen out of favor as a long-term prophylactic drug. So obviously we know it works. There's a strong recommendation. You do need to talk to patients a little bit about it. If you give them macrodantin, you need to talk to them about the prolonged usage and the problems with lung fibrosis with prolonged usage at high doses. And you also need to warn them that if they get a UTI, it's likely to be a more resistant type bug. So they do need to be ready for that. And if they do get a UTI on prophylaxis, they really should be having culture-directed treatment. It shouldn't be a shotgun treatment.
So what's Kefaclor? Is that
yeah, these are cephalosporins. I think they're second-generation cephalosporins. I think they're not all available here.
Yeah, I use quite a lot of Kefalex, and it's a first generation cephalosporin. It's marketed as Rancef, and in fact, I'm often use it instead of macrodantin, and it works quite well. So that's also not a bad option, but
yeah, it's
sometimes not an option. Yeah.
So all options.
Yeah.
Okay, then the post-coital one, as I said, it's as efficacious as continuous in those patients that get recurrent UTIs related to coitus. And it's particularly important in those patients who are pregnant, who have a history of frequent UTIs before pregnancy, because they're obviously at quite a bit higher risk of having that happen during their pregnancy as well. And once again, a strong recommendation. This is, as I said, once again, EAU recommendation. And then the last one is the self-administered. And I find this approach actually quite useful because a lot of patients don't want to take continuous antibiotics. And it does give patients quite a lot of, it empowers them quite a lot. Not all patients are suitable for this approach, but for the correct patient, it's excellent. I think one thing you do have to remember is if you are going to go this route, you need a safety net with the urine culture. So they have to take the culture before they start the antibiotics, and you need to have an understanding that that culture is going to be followed up so that if they have a resistant bug, that they're aware that they're going to have to take other antibiotics. And in this approach, you just give them standard short course antibiotics. And yeah, it does work. It's a good approach for the right patient. Okay, and it has a strong recommendation. So, as I said, there's not much new. So just in summary, just make sure it is a recurrent UTI and that it is the correct diagnosis. You don't have to investigate everybody. Just in some patients, they're the ones that are atypical or have other red flags. I think also consider using the over-the-counter or the non-continuous antibiotic approach, because there's reasonable evidence, and I think it really is important that one gives the patient those options. Some of them won't want those options, but I think you really should consider it and discuss with your patient. Don't forget the vaccines, they do work. And I think they're a lot more available now. I think this with the Euroimmune, people are really trying to make their product a lot more accessible and are giving quite a lot of support to doctors trying to prescribe the medication. Don't forget vaginal estrogens. We do often forget them, and they do help. Consider installations. I agree with Steve, though, they are quite a pain, and they are expensive. And then I think lastly, one has to remember that it's quite a marathon. These patients do need a lot of support. It is quite difficult to have recurrent UTIs. It has quite a severe effect on a patient's quality of life, and some of them do get quite despondent. And they do really need quite a lot of support. And unfortunately, they do need quite a lot of access. It doesn't have to be a specialist. If they have a good relationship with a general practitioner, that the general practitioner can be their point of contact every time they get a UTI, but they do need rapid access to care. And that's quite important that one creates that kind of pathway for them. So we're not all going to be setting records in the two oceans like Gerda, but I think in terms of trying to manage recurrent UTIs, it is possible, although it can be, as I said, quite a tiring and exhausting experience. So that's all I have.
Thanks very much, Lisa. It was a beautiful, comprehensive review and summary of the subject, and I think you've given us a lot of pearls to take with us and to move on to treating these patients. And thanks so much for the time you put into preparing and to presenting this talk. Gerard has just asked a question about screening for asymptomatic bacteriuria in pregnancy. Do you have any thoughts on that? I know it's more of an obstetric question, but
yes.
Yeah,
Yes.
but do you have any strong feelings about that? I mean, we know that there is a potential for developing pyelonephritis and the implications of that for preterm labor. I'm not sure. I'm also not an obstetrician, but any strong feelings on that?
I think you have to ask the obstetricians in the room. I mean, we've had a few problem patients that have developed stones in pregnancy or have developed recurrent, and those are problematic because then you have to cycle antibiotics, and that's a pain in the ass. We generally previously working at Recurrent Care, those patients are managed as high-risk patients and are basically drawn out from the community because they can be so difficult to manage. But I think in terms of the routine patient, a normal, just any obstetrician would be able to give you a better answer to that question. In some of our high-risk patients, like we've got some epispadias patients floating around, and we've also got some of our our cloacal extrophy patients, those patients we basically were looking, I think they were being seen almost monthly in the later parts of the pregnancy, just to actually have screening because they were at such a high risk for recurrent UTIs. Steve, I think you were involved with some of those patients who had prolapse after. I think we had 2 or 3 of them in the system.
We did.
But I think if they kept on a tight leash and they you know, and they are prophylaxed appropriately, they do fine.
Yeah, Marcus Fasson has said that asymptomatic bacteria is associated with high risk for preterm labor and therefore is advised to treat. I agree with that. The question is how long you should treat for, and should they take prophylactic antibiotic for the rest of the pregnancy. And yeah, I'm not personally sure on the guidelines for that, so unfortunately, I don't really have an answer to that. But thanks, Lisa, again. I mean, I just want to say I have been using the vaccine for about 7 months. It was made available in South Africa since January. I've got about 25 patients on it now, and yeah, that's what it looks like. Actually, it comes in a little box like that, and I don't get anything from the company, so don't worry. But it's a little spray. They take it every day and they put it under their tongue. And of all the patients that have been having it, not had one patient with any side effect or adverse event. In terms of efficacy, one patient has recently told me she got a UTI after taking 3 months of the vaccine. But you know, I think it's a nice new addition to our options, and yeah, I mean, it's an inactive vaccine, so I don't think any issues from that point of view. And yeah, I look forward to seeing how it actually works. I mean, it obviously does depend on the patient's specific risk factors. And you know, sorry, Lisa.
Sure. This is some of the kind of the things I've lifted out of some of the early publications. I think there's about 3 or 4 of them now. Looking at Euroimmune, the initial studies. So I mean, it looks quite compelling, but this is a 3 and 6 month follow-up. So I mean, one doesn't know how long it's going to work, but it definitely does seem to have a significant decrease in UTI episodes.
That's Klebsiella, E. coli, Proteus, I think, and Enterococcus. Those are the 4.
Yes.
And obviously, if the patient's going to have a different strain of E. coli, they're going to get a UTI. But you know, I mean, if we're on the ropes with a lot of these patients, and I always say to patients, like an immunostimulant, which might be better than taking macrodantin or an antibiotic each time. So, you know, and maybe a local audit is quite a useful thing. But yeah, we look forward to the results on that. Lisa, thanks. That's a great summary. There aren't any other questions at this stage, so there's nothing further to be asked. Yeah, thanks to everyone for joining. Thanks again to Lisa. And I'm sure Lisa would be happy to see some of your patients who have these difficult problems. And she's in full-time private practice now at Chris Barnard. So yeah, we look forward to further discussion about these and other issues related to recurrent UTIs. So thanks so much. And yeah, we look forward to seeing you next week. We'll send out an advert. We haven't confirmed the speaker for next week, but we'll be sending that to you all soon. And again, thanks. We had a great turnout tonight, and we thanks to everyone. Keep warm, and we'll see you all next week. Thanks so much.